Welcome everyone, and thank you for joining our parent and carer self-harm awareness session. My name is Lisa and I'm joined by Rebecca, and we both work for the mental health support team. Always remember to take care of yourself. We will be talking about an emotive subject, and there might be moments when you need a couple of minutes to take some time out. It's okay to have a pause and come back when you feel ready. Be kind to yourself. So the aims of the session are to explain the term self-harm and self-injury, to identify ways in which people can self-harm, to explore why children and young people self-harm, to identify practical strategies to use when supporting your child or young person who self-harms, to explore healthy ways of expressing emotions which parents and carers can support their children and young people with. What is self-harm? The definition of self-harm, which is from NICE guidelines, that's the National Institute for Health and Care Excellence, defines self-harm as self-poisoning or injury, irrespective of the purpose of the act. Although some people who self-harm may be suicidal, I think it's important to remember that self-harm is often used as a way of managing difficult emotions without being a suicide attempt. However, self-harming can result in accidental death. It's also important to remember that there's no safe way to self-poison. Self-harm can be a risk factor, and therefore it's important to ask children and young people if they do feel suicidal. Talking about suicide does not increase the risk of suicide. Here are some examples of self-harm. The bottom line is that anything that causes you harm, even slight harm, which in some small way makes you feel better emotionally, can fall under the umbrella of self-harm. The important thing isn't to focus too much on the labeling, but to recognize when help is needed and find some support as soon as possible. Ways to self-injure are most commonly inflicted on the arms, hands, and wrists of the individual, but other body parts, such as thighs or the stomach, are also commonly reported. Getting into fights when you know you'll get hurt, risk-taking behaviours may not be commonly thought of as self-harm, and we may see this perhaps more in males. Eating disorders and addiction behaviours are not typically considered methods of self-harm, but in some cases they may be if the intent of their use is specifically to cause harm to the body. For many, self-harm and an eating disorder coexist, but for others, self-harm can develop to replace an eating disorder or vice versa. If someone tries to give up their harming when they are not psychologically ready, for example, doing it to please someone else, then another self-destructive symptom can easily develop in its place. Unintentional self-harm occurs when a person engages in an activity in which bodily harm arises as a consequence, although this is not the main objective. Examples include smoking and drinking alcohol for pleasure and participating in dangerous sports. In general, these are all myths. We mustn't assume and put all young people who self-harm into categories or boxes. Language matters, as does the impact of language. Manipulative is a loaded and judgmental word which has negative connotations. These terms can be stigmatizing. More helpful language, instead of attention seeking, may be in need of attention or support. We all need attention. It's not necessarily a negative thing. If someone's doing this to get noticed, then something's gone fundamentally wrong and they need our attention and help. Self-harm is not generally a pleasure-seeking exercise. It's often the desire to be seen and be heard when we're hurting. There is no evidence of self-harm being associated with subcultures. It's often secretive. Young people are often drawn to others who have similar challenges. It's good to be aware of technology, websites, forums, which encourage self-harm. As we've mentioned, there can be a link between self-harm and suicide. However, self-harm is more often used as a means of coping rather than a suicide attempt. Personality disorders are not diagnosed until 18 plus. Some of this is normal teenage behavior, including mood swings being very common. Self-harm within itself is not a diagnosis of mental illness. This is a cycle of self-harm. Take a few minutes to look at this cycle. You might even want to pause the session. The important part as parents and carers to take from this is the guilt or shame component of the cycle. This is where you could potentially intervene. If a young person feels guilt or shame, it can exacerbate their self-harm. If parents can be aware of this and actively reduce stigma in the home, it could work towards disrupting the cycle. There are many reasons why people self-harm. Here are some of them which may be relevant to your child. Please take a few minutes to look through. You might want to pause the session again. It's worth noting those who have a neurodiversity, such as autism, are more likely to experience mental health difficulties. However, in terms of self-harm, understanding its function and why young people are engaging in that behavior is really crucial. It may often be about them regulating their emotions and senses, such as stimming, head banging, or picking scabs.
Explanation of emotional arousal. It may be helpful to understand some of the physical and neurological processes that can happen in the lead up to self-harm, so you know what is happening for the young person and help guide which type of coping strategy is going to be the most helpful at each stage. So let's start by defining distress. We will break down distress into 4 areas: emotional feelings, thoughts, physical feelings in our body, and neurological processes. These all impact on how a person may respond in a situation or what they may do, for example, self-harm. It is important to note these are examples of symptoms and experiences. However, they can vary depending on the trigger, the situation, and the person. Let's first look at emotional experiences. There could be various emotions that are included in the term distress. For example, anxiety, sadness, anger, disgust, or maybe even numbness. And when distressed, these emotions start to increase in intensity. Regarding thoughts, there may be an increase in what we call negative automatic thoughts, which could include self-criticism, worry about the future, rumination of the past, or more. And of course, we don't just think in words. People often think in imagery too. And so a young person could be picturing or remembering a situation that has happened, experiencing a flashback of a past trauma, or imagining a scenario which could happen in the future. Physically, when distressed, our bodies respond to messages our brains send, telling us that we are under threat, and therefore initiate a process often called fight or flight. We'll go into a little more detail on that shortly. This reaction can create some quite uncomfortable or overwhelming physical symptoms. For example, experiencing chest pain, palpitations, shakiness, an increase in temperature, and many more. We can see more examples on the diagram on the right. From a neurological perspective, we return to the fight or flight response. What this refers to is the primitive part of our brain which is responsible ultimately for keeping us safe and alive. It responds to threat by activating this red and yellow part of the brain, as you can see on the diagram, which tells us this is threatening, I need to get out, or I need to fight. Now, whilst we have evolved long since our primitive and reptile ancestors, our brain still responds to modern day threats, such as friendship difficulties or taking a test, in very much the same way it would have responded to being confronted by a predator. The main thing that separates us from our primitive ancestors is this green bit of a diagram, the prefrontal cortex. This is the bit that evolved last and is responsible for higher order thinking, such as decision making and problem solving. Now, the main problem is that the higher the distress, the more active these red and yellow parts become, and the quieter the green part is. Our brain decides we don't need all that fancy extra green stuff, we just need to survive. But unfortunately, that can lead to quite impulsive behavior such as self-harm. So, to help understand how distressed a young person may be feeling, we often use what we call a distress thermometer. We encourage its use with clients and with parents and carers too. This is a symbolic way of being able to gauge the level of distress a young person may be experiencing. We imagine that the thermometer is broken down into 3 zones. 0 to 3 at the bottom of the thermometer is cool. The cool zone means that the young person is experiencing low levels of distress, therefore low physical arousal, low intensity of challenging emotions, few negative automatic thoughts, and therefore we don't expect the fight or flight response will be activated. So that green part of the diagram, the prefrontal cortex, is very much engaged. Then there is 4 to 7 on the thermometer. This is what is sometimes termed as the challenge zone. This is where the young person is experiencing heightened and challenging levels of distress. This is an opportune stage to prevent self-harm, if that's what the young person's goal is. And they have different techniques and options that they can use at this point. If we look at this image here with the green circle, there are 5 areas, most of which you will recognize from earlier: thoughts, feelings, bodily sensations, behaviors, and the situation. Ultimately, we are trying to change how the young person feels. We want them to feel less distress, and so there are 4 opportunities or approaches that could do that. We could change the situation, which would be great if possible, but often we can't. For example, dealing with a past trauma which has already happened, or having to do exams. So then we are left with 3 remaining options: changing the behaviors, thoughts, or bodily sensations. And we'll cover some coping strategies for each of these areas later in the workshop. This leads us to the final part of our thermometer, 8 to 10. This is often where distress becomes so overwhelming for the young person, and so this is the point when self-harm is most likely to occur. At this stage, that green, rational part of the brain is very quiet, which means that decision making and problem solving is going to be quite poor. It also means thinking coping strategies are likely to be minimally effective, and it will also be pretty challenging to reason with the young person at this point. Therefore, at this stage, we would recommend concentrating on physical and behavioral coping strategies. This primarily focuses on calming down the body. Just as the brain can send messages to our bodies to tell us that we are unsafe, if our bodies are calm, it sends messages to our brains that we are safe and starts to end the fight or flight response and activates the soothing part of our nervous system. This calms the young person down and hopefully brings them down on their thermometer to a more manageable, cool, or challenge zone, which feels less distressing, makes people less likely to act impulsively, and allows them to choose how they would wish to respond. Supporting your child, starting a conversation. So, the first half of this workshop was all about understanding self-harm. This next part is about how to support the child, and that all starts with a conversation. The first tip is not to bring up self-harm straight away. Being too direct when you open a conversation could cause the young person to become defensive or close up. Instead, you may wish to ask if anything is worrying them and how they're feeling, This is more likely to address the reasons why the young person is self-harming than the self-harm itself, which is likely to be more important to them. You can also try saying what you see. Just like the TV show catchphrase, describe what you observe. This technique can be used to start a conversation or during one. For example, you might say, I can see that you haven't been going out much recently. I have noticed you have been spending more time in your room alone. Or, I can see that bothers you. It allows the young person to fill the gaps. You know that there is something wrong. This gives them the space to expand without us presuming. Choosing the right context can be important too. We sometimes recommend what we call car conversations. This involves starting a conversation in situations where you don't have direct eye contact. This can be helpful when having difficult conversations as it facilitates a non-threatening environment with minimal distractions. This can feel more natural and easier for the young person to talk. Other examples of doing activities where you're side by side may include cooking, doing a puzzle, or walks. Young people will be receptive to your feedback during these conversations, so you may wish to drive the van. VAN stands for validating, acknowledging, and normalizing. Let's start with acknowledging. Acknowledge what the young person is saying. Indicate that you have heard them and that you are listening. To demonstrate this, you can try paraphrasing. So saying what they have said to you back to them in a slightly different way or different words. Validating. Validate your child's emotions. They are real and they are important. We want to send a message. If it's important to you, then it's important to me. Remember, it's not the size of the problem that is important, it's the size of the impact. We may be familiar with phrases such as, it's just hormones or it's just a phase, but these passive phrases can have a big effect. Instead, validating phrases may sound like, that sounds really tough, or I can see that's really upset you. Normalizing. This involves communicating that what the young person is experiencing is normal. Lots of young people won't open up because they are worried that something is wrong with them, or it might make them seem odd. We want to communicate that emotions are normal. Sadness, fear, anger, we all experience these emotions and they're part of the human experience. We can normalize by relating that message back to other young people or even your own experiences where appropriate. So normalizing may sound something like, you're not alone, or I felt that way before. Another aspect to be mindful of in terms of feedback is adopting a non-judgmental approach. Ultimately, judgment can lead to withdrawal, so it is wise to be mindful of not only what is being said directly to the young person, but indirectly too, as expressing judgment about others' mental health could be a barrier to your own child opening up about theirs. Some young people struggle to articulate how they're feeling or expressing upsetting emotions, thoughts, or feelings verbally. The main thing is that there is communication between the child and their parent or carer. The method isn't as important. And so, if your child doesn't want to talk, see if they'll write you a note, email, or text message about how they feel instead. Once the conversation is open and the young person's feelings and experiences have been validated, try to deal with the self-harm in a matter-of-fact manner. We will explore how in the next slide, but this point is to really acknowledge how emotive it can be for parents and carers to have these conversations. Therefore, it's important to choose a time and environment that you're in the right emotional space to have this conversation, so you're emotionally available and so your feelings and judgments don't lead the conversation, and to be able to deal with the self-harm in a matter-of-fact manner. But we also acknowledge this is easier said than done, so there can also be a couple of tips to support parents and carers' well-being in the upcoming slides too. Supporting your child, addressing self-harm together. If your child is ready to consider reducing or stopping self-harm, there are various approaches which may help. Firstly, Try to help them work out feelings and situations which may trigger it. Thinking back to the cycles on previous slides, what patterns have they noticed in terms of the situations, thoughts, feelings, and behaviors that lead to self-harm? If they can identify the triggers, then they will be better equipped to reduce or manage them, which leads to think of ways to handle strong feelings that don't involve self-harm. It can be particularly helpful to draw on the experiences of approaches that have worked well in the past. Not only do we know that this approach has been effective and therefore like to be effective again in the future, but it also orientates the conversation to the young person's successes and therefore positive for their self-esteem. Help them to think through their problems and see possible solutions. By encouraging young people to come to their own solutions, you're teaching them problem solving and reinforcing the message that they can cope. If you try and solve it for them, it could lead them to believe, this is too big, I can't cope with strong emotions, or I need a parent or carer to fix it for me. Instead, we might try phrases such as, that sounds really difficult, what do you think will help? Or, what can I do to help you? This can be quite empowering for the young person to take control of the problem. If you think it's appropriate to give advice, ask first. Giving people unsolicited advice can activate their threat system and a perception of social dominance, which can lead to withdrawal and disengagement. Instead, we might ask, is it okay if I share something with you that I think will help? Or, I know someone who's experienced something similar. Can I share with you what helped them? However, be cautious when going into problem-solving mode, as a solution may not necessarily be what the person needs in that moment. Instead, they may just wish to express their emotions and feel safe and comforted whilst they do so. It can be a natural instinct of parents or carers that if they see that their child is sad or experiencing other negative emotions, that they want to take it away from them and for them to feel happy. However, sometimes it's okay to simply feel sad and be with them as they feel it. They may just need a cup of tea, a cuddle, or to watch a Netflix series with someone whilst they side on the sofa. Sometimes acceptance can be more helpful and powerful than resisting or trying to change the situation or the problem. It may be a bad hour, bad afternoon, bad day, bad week, and sometimes simply riding a wave and being by their side as they do can be the best approach. Encourage them to think about the long view and how things may change in the future. Ask your child, how do you think you might feel about this in an hour, a day, a week, a month, or even a year, to help them see the bigger picture? Remind your child of their strengths and abilities. Back to the point about positively orientating the conversation, it is important to highlight and draw on a young person's strengths and abilities, as these are often the key to finding effective alternatives to self-harm or motivating them to make changes if they are ready. For example, we often find creative young people use art as an outlet, which can be incredibly cathartic for them. Work out with your child how to make it more difficult for them to self-harm. This tip involves identifying what makes your child feel unsafe and making changes to the environment to help reduce the chances of a child acting impulsively. Take talk of suicide seriously. Sometimes suicide can be mentioned in a context that may not always seem sincere, such as by use of sarcasm, humour, or in a highly emotive state, but this can come from a very real place. Therefore, all talk of suicide should be taken seriously and addressed. Ask if they would rather speak to someone else. There are lots of reasons why a young person may not wish to speak to their parents or carers about self-harm. For example, feelings of burdenism, embarrassment, shame, if there's relationship difficulties, or thinking that their parent or carer won't understand. And often, with parents and carers' best intentions, will and efforts, their child won't open up. In these instances, you may wish to direct them to another trusted adult, such as a GP, counsellor, a helpline, or school contact, such as a pastoral lead. Supporting your child. you and your child. We acknowledge that self-harm can be a very emotive subject and can sometimes impact on the relationship between the parent or carer and child. And so here are some tips and reminders that may help maintain that bond. You don't understand. This is a common phrase that we hear, my parents don't understand. That's ironically usually coupled with parents and carers who are desperate to understand. Parents and carers are expected to know everything, but actually it's okay not to understand. The child is the expert in themselves and how they feel, and everyone experiences emotional health difficulties differently, so it's okay not to fully understand. The important thing is to send the message, even if I don't understand, know that I want to. Don't let self-harm become the focus of your relationship with your child. Continue to have conversations about everyday things and the young person's interests, and do activities together that you enjoy. Keep in mind the entire child and who they are, not just the self-harm behavior. Reassure them that you do not think that they're a failure, whatever their difficulties. Young people will often worry that their parents will think negatively of them for self-harming, which can lead to secretive behavior. Remind them frequently that you are proud of their efforts and not focusing primarily on the outcomes. This is particularly important as slips, lapses, and relapses are common when trying to reduce or stop self-harm, and so they need to know that this is a normal part of the overall journey and not a failure. Let them know that you love them, and that will not change. It can often be assumed that young people know that they are loved, but it is important to remind them, particularly those who are emotionally vulnerable. And it is important that they know that this love is unconditional. It's me and you versus the problem, not me versus you. It is common for carers or parents to say that they will try to open a dialogue and it often results in an argument or conflict. They don't remember how it escalated. If your child is struggling with their mental health, imagine that they are swimming in a sea of emotion and you are on dry land. Don't step into the sea. Avoid being drawn into an argument or conflict about self-harm, as it often just widens the gap. People can project their emotions, and it can sometimes be a symptom of the difficulty that they're experiencing, such as withdrawing if they have low self-esteem or low mood. It can be helpful to externalize and see the emotional difficulty as separate from the young person who they are. It's not who they are, it's something that they're going through or experiencing. They are a young person experiencing an emotional health difficulty. They are not the emotional health difficulty. In the same way that someone is not diabetes if they have that. Remember, ultimately, you're on the same team. Don't blame yourself. Many parents will ask why their child might be experiencing emotional health difficulties or blame themselves. In reality, there is very rarely a single reason, but a combination of factors. Understanding the factors that lead to the challenges can help, but blame and self-criticism serve little purpose and can act as an obstacle to moving forward. However, because of your substantial impact, there are opportunities to improve the situation by your example, which leads to being a role model. Talk about your own feelings, label them, encourage emotional language in the home, and demonstrate how you are coping with difficult emotions. This helps normalize the young person's experiences, as we spoke about earlier. Look after your own mental health. Just as on an aeroplane, they will ask you to put on your own oxygen mask first before putting on the child's, it's similar concept in regard to mental health. One of the best things you could possibly do for your child's mental health is to look after your own, for various reasons, including that firstly, they will interact if you're both struggling, and secondly, that they will learn from you. If you demonstrate practicing coping, seeking support, they will learn that too. If you need support, don't hesitate to ask. And if that's something that resonates with you, then please talk with your GP. Safety planning. A safety plan is a tool to help navigate challenging emotions when the young person feels like self-harming or experiencing suicidal thoughts. It is recommended that these are written out and shared with people relevant to the young person's safety and care. There are safety plan templates provided on the recommended resources at the end of the presentation. Identifying support networks. Identify positive contacts who can support the young person, such as family, school contacts, GP, any services who may be involved in the young person's care, and helplines. Make sure the young person has the contact details for each, that they are accessible to them, for example, written on a safety plan or in their phone, and that they know who to contact under which circumstances. Creating a safe environment. Creating a safe environment helps reduce the chances of the young person acting impulsively. Planning may focus on any environment where the young person can feel unsafe, such as home or school. The Safe from Harm diagram, provided here on the right, is another recommended resource you will find a link for at the end of the presentation. Safe storage. Keep all medicines, cleaning products, and harmful fluids out of reach and locked away. Keep garages and sheds locked. Minimizing harm. Have a first aid kit in the home. Keep an eye out for any changes in mood or behavior. Reduce isolation. Encourage spending time with family and friends. Make plans of things to look forward to. Communication. Provide opportunities to talk. And as discussed earlier, think of other ways you can communicate other than talking. A popular option, which we often recommend, is agreeing an emoji system. This involves agreeing traffic light emojis which communicate how safe a young person is feeling. Green indicating that they feel safe, amber is so-so, and red meaning that they feel unsafe. You can then agree with the young person what they would find most helpful in terms of support at each level. Making the young person aware of out-of-hours support. This could include helplines, emergency services, or the CAMS crisis team. This is to ensure that the young person is aware that the support is available 24/7 at all levels. Discussion with young person about sharing this safety plan with significant others. It is vital that the young person is involved in their safety planning. This plan may need to be shared with others. For example, if they have shared care across different residences, other family members, or perhaps even school. Have a conversation with your child about who else you should share the plan with. Managing injuries from self-harm. Cuts and wounds. Apply pressure to bleeding cuts using a bandage or towel. A tea towel may be less likely to stick to the wound. Clean the wound under running tap water and apply a sterile adhesive dressing. If the wound has become infected, for example, if you notice swelling, pus forming, spreading of redness or heat, encourage your child to seek medical help. Managing injuries from self-harm. Overdoses. Get your child to an emergency department as soon as possible. This is as there is no safe way to overdose. Try to find out what they have taken and tell emergency medical staff. If your child won't tell you, look around for empty pill bottles or blister packs. Managing injuries from self-harm. Burns. Cool with cold water for 10 to 30 minutes. Then cover them with cling film. Don't use ice or any creams or greasy substances such as butter. Scars. If your child has scars they are embarrassed about, you can look into commercial products that may help them fade. Scars can also be covered by use of makeup. Remind your child that most scars will eventually fade. At an earlier point in the presentation, we recommended that there may be different techniques to help reduce emotional arousal. At the highest levels, from the 8 to 10 on the thermometer, we would recommend behavioral and relaxation techniques to be able to reduce distress. Here are some examples of techniques that the young person may wish to try. Mindfulness. Mindfulness means maintaining a moment by moment awareness of our thoughts, feelings, bodily sensations, and surrounding environment through a gentle, nurturing lens. Mindfulness can be achieved via different exercises such as meditation. Deep breathing. Deep breathing exercises can assist in activating the calming part of the nervous system. Grounding techniques. Grounded techniques are strategies that help a person manage upsetting thoughts or strong emotions. The intention is to bring the person back to the here and now. Self-soothing are activities that a person may use to help regulate their emotional state. These are usually based on the different senses and can include things such as soothing imagery, listening to soothing music, or having soothing smells. Recommended resources, websites and videos. Would recommend at this point that you pause the presentation to be able to make note of some of the recommended resources that we have provided on this slide and the upcoming slides. This slide has a list of recommended websites and videos. Recommended resources, apps. Recommended resources, books and videos. Your feedback is very important to us, so we can improve and continue to meet the needs of parents and carers. Please take 5 minutes to feedback on today's session by following the link below or opening your phone camera to the QR code on the right. Thank you for listening to our presentation.